Welcome back to Decoding Respiratory Medicine, your trusted source for informative and engaging content on health, medicine, and everything in between. I am Sidra Fayaz, and today I'm going to discuss a topic of utmost importance, the Nipah virus. Nipah virus has recently gained a global attention due to its potential for outbreaks and its impact on public health. In this video, I am gonna dissect this virus, exploring its origin, transmission, symptoms, and the measure we can take to prevent its spread. With the recent concerns surrounding an infectious diseases like after COVID infection, understanding the virus, especially now the Nipah virus, is more critical than ever. So, whether you are a healthcare enthusiast, a student, or simply curious about latest developments in the field of virology, you are tuned into the right place. So, if you're ready to the journey to the world of viruses and pandemics, don't forget to hit the subscribe button and ring the notification bell so you never miss an update. Let's start by demystifying the Nipah virus. So, coming towards an introduction, Nipah virus can be abbreviated as NIV, as an RNA virus that belong to the family of Paramyxoviridae and Nipah virus. Nipah virus is first caused an outbreak in pigs and humans in Malaysia and Singapore between 1998 and 1999, and has caused a recurrent human outbreaks in Bangladesh and West Bengal, India since 2001, and in Kerala around 2018. Outbreaks have also occurred in Philippines in 2014, and as I told, in India, Kerala 2018. Let's talk about transmission. As you can see, this diagram on the presentation slide, it is an RNA virus, and this is the structure of a virus of genus Pteropus. The primary reservoir of Henipa virus are bats, and they are isolated from the urine of bat. Other animals are maybe an intermediate host, and we can isolate the virus from a fluid, urine, saliva, bronchial secretions of the animals. Human infection results from spillover transmission from bats or other, or maybe through human to human transmission. Domestic animals such as cats and dogs were also shown to have a positive serology for Nipah virus. Nipah virus is a zoonotic disease, and with the reservoir is the bats, and it can happen if the fluids are spilled over from the bat secretions and came in contact with the other human being or other animals as well. Let's go into some of the pathology. So it spreads through oronasal routes into human and other hosts. High concentration of antigen in the lymphoid and the respiratory tissue suggest that these are the probable sites of initial replication. Nipah virus infects the epithelium of respiratory tract and induces inflammatory cytokines leading to the development of ARDS. The main pathology appears to be a widespread ischemia and infarction, and this is the thing which is causing encephalitis. And in the brain, Nipah encephalitis have included necrotizing vasculitis and sensual formation. Eosinophilic cytoplasmic and nuclear viral inclusions were also detected in neurons adjusted to the vasculitic vessels. And findings which may be present in infections caused by other paramyxovirus may also be there, but it can cause an extensive and confluent parenchymal necrosis, edema, and inflammation. But without vasculitis, it can cause endothelial syncytial formation and thrombosis as well. Currently, it is spreading in South and Southeast Asia. Let's go to the second part, which is signs and symptoms. So, symptoms starts with fever, headache, dizziness, vomiting, followed by a rapidly progressive encephalitis, resulting in drowsiness, disorientation, confusion, and sometimes coma. Among CNS symptoms, decreased level of consciousness, brain stem dysfunction, myoclonus, areflexia, hypotonia, cerebral signs are commonly observed. In fluent illness, you can see a patient with a multi-organ dysfunction, GI bleeding, and renal failure. And 69% of the patient has a respiratory difficulty in outbreaks in Bangladesh. And some cases led to ARDS as well. Long-term neurological effects from encephalitis were observed as a fatigue, encephalopathy, ocular motor palsies, cervical dystonia, focal weakness, facial paralysis, and in a small proportion of patients, the onset of illness may be delayed, but there may be relapses after recovery from an acute infection. So, how you're gonna diagnose it? Laboratory findings. in in the full blood count, leukopenia, thrombocytopenia, and in LFTs could be deranged, like ALT, AST are commonly raised. CSF analysis in most patients showed an elevated WBC counts or protein levels, or maybe both. In acute Nipah virus infection, virus specific antibodies were present in serum in more than 70% of the samples, but in less than one third of a CSF samples. The presence of virus in CSF culture was strongly associated with the mortality, and EEG and encephalitis show a bilateral temporal periodic complexes of sharp and slow waves. Those were occurring every 1 or 2 seconds. And a typical MRI findings were multiple 2 to 7 lesions, and they were best visualized in T2 weighted images in the subcortical and deep white matter of the cerebral hemispheres. Periventricular areas in corpus callosum without associated cerebral edema or mass effect. And a few patients were also seen with the leptomeningeal enhancement or parenchymal lesion enhancement. Nipah virus can be detected from urine and respiratory secretions by culture and PCR. So, real time RT PCR is more sensitive than conventional assay, and serology is not helpful for acute infections but mostly useful for epidemiological studies. So, now the most important part, treatment. What is the treatment for Nipah virus till now? What we have? So, Nipah virus is considered as a biological safety level 4, BSL-4, pathogens due to the unavailability of effective treatment or vaccination against it. Up till now, I'm giving the presentation. We have no certified treatment. Patients with NIV infection should be isolated with the infection control practices in place, and treatment is primarily supportive right now. um, Ribavirin is an antiviral that is effective against other paramyxoviruses like the respiratory syncytial virus, and reports on its efficacy are right now unclear, with conflicting reports showing a reduction in mortality and some with no effects. However, the Indian National Center for Diseases and Control recommended the use of ribavirin in Nipah virus infections, and they also recommended acyclovir, chloroquine, and Eprin B2. They are currently under review as a therapeutic options. Uh, Favipiravir, which is licensed for the treatment of influenza in Japan, was shown to be effective in hamster. The human monoclonal antibodies has been shown to be useful in ferrets and non-human primates. Patients should be discharged only after negative RT-PCR is performed on a throat swab, and discharged patient remain in isolation for 21 days following the confirmation of the virus. So these are all guidelines up till now. It might change in the future. And with that, you can go for a supportive treatment, like if, for example, patient is dehydrated, fluid resuscitation, anti-epileptic if having seizures, antipyretic if having temperatures. So differential diagnosis could be Japanese encephalitis, measles, rabies, dengue encephalitis, cerebral malaria, typhus, leptospirosis, herpes encephalitis, and bacterial encephalitis as well. For up till now, prognosis, the case fatality rates can range between 40 and 100%. Poor prognostic factors are there, and they are old age and severe brain stem involvement. Prognosis and case fatality rates also depend on the strain of the virus as well. For example, the Malaysian variant is showing a lower rates. Complication, there may be a residual neurological deficits in survivors, including behavioral change, cervical dystonia, ocular motor palsies, weakness, and facial paralysis. In a small proportion of patients, there may be a relapse from the recovery. Thank you so much for your time, and I hope you like this presentation. Kindly like and subscribe and share. Thank you.